Howdy everyone, welcome back to MSK. My name is Jonathan, and in this chapter we are going over the one net you can never escape from, the brachial plexus. For our first video, we're just going to do an anatomical overview, talking about the roots, trunks, divisions, cords, and branches that make up the brachial plexus. In the following videos, each of the terminal branches of the brachial plexus will get to be the star of its own episode. So we'll talk about the musculocutaneous nerve, axillary nerve, radial nerve, median nerve, and last but certainly not least, the ulnar nerve. In each of those videos, we'll talk about the nerve roots, the motor and sensory innervation, and the common causes of injury you're likely to see in a board question. And once we've gone over the normal anatomy, then we'll talk about 4 important lesions of the brachial plexus: Erb palsy, Klumpke palsy, thoracic outlet syndrome, and winged scapula. For each of those, we'll go over the pathophysiology, causes, presentation, and of course, the treatment. So if you're ready, let's hop into it. Before we get into the nitty-gritty of all the intersections and trunks, divisions, and all the offshoots, let's talk a little bit about anatomical context. So we're going to start in the cervical spine where the roots come off of, and it's going to head down the arm, past the axilla, and innervate all the muscles and skin of the arm. So now that we have an understanding of the anatomical position, we can take a closer look at our pretty little diagram. This is a great diagram to reference as you're learning all of these nerves because all of the colors demonstrate the nerve roots of those nerves. So you can choose any nerve, the median pectoral nerve, and see that the purple and yellow lines leading up to it show that it has C8 and T1 as a root. All right, let's start with the roots of the brachial plexus. So there are 5 roots, C5, C6, C7, C8, and T1, all comprised of the ventral rami from the spinal cord. So let's talk a little bit about some of the nerves that come off of these roots that are not the terminal branches. So first we'll have, coming off of C5, the dorsal scapular nerve. So that's this one right here. And so that's going to innervate a couple of muscles, including the rhomboids, levator scapula, and the role of those muscles is to act to stabilize the scapula. Also coming off of root C5 is the phrenic nerve right here, which innervates the diaphragm and has the very important task of helping us breathe. Remember that the diaphragm is also innervated with roots C3 and C4, but those are not a part of the brachial plexus, so we don't have them pictured here. And the last nerve that comes off a root will actually share 3 roots. C5, C6, and C7 are all coming down to innervate the long thoracic nerve. This innervates the serratus anterior, which is a muscle that helps to bring our scapula forward, sometimes called the boxer's muscle, because you can imagine as a boxer's throwing a punch, this is the muscle that gets very heavily activated. And finally, to talk a little bit about the positioning of the roots themselves, they're going to be superior and posterior to the subclavian artery. So if I were to draw that in on our little diagram man down here, I might put the brachial artery right about there, also going under the clavicle like the brachial plexus. And next we'll talk about the trunks of the brachial plexus. So up top we have the superior trunk, which is combined of the roots C5 and C6. We have the middle trunk, which is just from the root C7. And we have the inferior trunk comprised of C8 and T1. And up next, we'll talk about our divisions. Now, divisions aren't so important in the sense that you need to memorize what all of their names are for a question, but they're important to understanding the plexus itself, understanding how the different cords are made of the different trunks and roots. That being said, there are 3 anterior and 3 posterior divisions for a total of 6. So we'll have 1, 2, 3, 4, 5, 6 total divisions. I'm going to give you a little bit of a spoiler and jump ahead and let you know that this right here is the posterior cord. And I'm only going to ruin that surprise for you to let you know that it's easier to remember that's how these divisions are labeled. So all of the divisions that lead to the posterior cord are posterior divisions. So we'll have 1, 2, 3 posterior divisions, and that leaves us with 1, 2, 3 anterior divisions. All right, now let's move on to the cords. Now this is where it starts to get a little fun. So there are 3 cords in the brachial plexus, and they're all named relative to their position to the axillary artery that's also running through the arm. So if you can imagine, the axillary artery might be running somewhere along in here. And so that's how the posterior cord gets its name behind the axillary artery. We'll start at the top of our diagram with the lateral cord. That's this right here. And the important thing to know about the lateral cord is that coming off of it is the lateral pectoral nerve. and that's going to be a major innervator for the pectoralis major. And as a reminder, the actions of the pectoralis major muscle are internal rotation, adduction, and flexion of the humerus at the glenohumeral joint. But really, I just think about it as the one for bench pressing. Onto the posterior cord, we have three nerves coming out of this: the lower subscapular nerve, the upper subscapular nerve, and the thoracodorsal nerve, which is sometimes called the middle subscapular, but really know it as the thoracodorsal nerve. So this thoracodorsal nerve is going to be innervating the latissimus dorsi. And again, the actions of the latissimus dorsi are extension, internal rotation, and adduction of the humerus at the glenohumeral joint. Additionally, the latissimus dorsi does insert onto the scapula and spine, allowing downward rotation of the scapula. But really, I just remember this as the one for pull-ups. Now, talking about the subscapular nerves, the lower subscapular nerve is going to innervate the subscapularis and teres major, while the upper subscapular nerve will just innervate the subscapularis. So the subscap and teres major are shoulder girdle muscles, and those are going to help adduct and internally rotate the humerus. And the last cord we're going to talk about is the medial cord, running along here. And the important offshooting branch that we're going to talk about is the median pectoral nerve, also innervating the pectoralis major in addition to the pectoralis minor. And the important action of the pec minor is to act as a stabilizer for the scapula. And lastly, we have the branches of the brachial plexus: the musculocutaneous nerve, axillary, radial, median, and ulnar nerves. Now, each one of these is going to get their own episode, so be sure to watch those for all the juicy details about their innervations and causes of injury. Let's do a quick recap, and then we'll go over a practice question together. So our 5 roots are going to come off of the spinal cord, C5 through T1. Together, they're going to form the superior, middle, and inferior trunks. Then those trunks are going to go through their anterior or posterior division to form the lateral, posterior, or medial cord of the brachial plexus. And lastly, they will form the 5 terminal branches that we are going to learn about later. So a question might sound something like this. A 24-year-old male comes to your clinic 2 weeks after a mountain biking accident. He says that normally he recovers well after the accident, but since this one, he's noticed he's having more difficulty breathing and can't throw as fast during baseball practice. On physical exam, lungs are clear to auscultation and heart sounds are normal, but you notice right-sided muscle wasting despite him being right-handed dominant. What terminal branch of the brachial plexus was most likely spared in the injury of this patient? So the clues that he is struggling to breathe and is having difficulty throwing during practice hint us toward phrenic nerve and dorsal scapular nerve damage. And if you trace out the brachial plexus, there's only one terminal branch that does not have C5 as a root, and that is our ulnar nerve. All right, everybody, that's all I have for you about the brachial plexus. Join me next time as we talk about the musculocutaneous nerve, and I'll see you then. Howdy, everybody. My name is Jonathan. Welcome back to your MSK unit, and today we are continuing our adventure of the brachial plexus, and we will be talking about the musculocutaneous nerve. Let's get into it. Before we get into our slide, I think it'd be a good idea to go over our diagram and talk about the roots that lead up to the musculocutaneous nerve. C5 and C6 are going to join together to form the superior trunk, which will then go on to form the musculocutaneous nerve. Additionally, C7, which adds to the middle trunk, will have an anterior division, which then also contributes to the musculocutaneous nerve. So as we just mentioned, going over the nerve roots of the musculocutaneous nerve includes C5 to C7. Importantly, this also includes the C5-C6 biceps tendon reflex. So in this reflex test, the biceps tendon is struck with a hammer in the antecubital fossa. In a healthy patient, this will elicit the biceps contraction, which will cause sort of a jerky motion of the arm. If there's nerve damage to the musculocutaneous nerve, there might be a reduced or a diminished biceps tendon reflex. Oftentimes, question stems will include the biceps reflex to rule in or rule out nerve damage. All right, next up, we'll talk about the motor innervation of the musculocutaneous nerve. Starting off small but mighty with the coracobrachialis muscle right here. This muscle will help flex the arm at the shoulder joint and also help stabilize your arm when you're carrying a very, very heavy weight. The musculocutaneous nerve also innervates the biceps brachii, this muscle here. Although commonly known as the reason for Tank Top Tuesdays, importantly, this muscle also flexes the elbow and because of its insertion onto the radius, supinates the wrist. And the last muscle we'll talk about is the brachialis, this muscle here, which is a pure flexor of the elbow. Importantly, the brachialis has dual innervation. It's innervated medially by the musculocutaneous nerve, and it's innervated laterally by the radial nerve. And so before we move on, let's talk a little bit about these three muscles. So together, they sort of constitute the anterior compartment of the arm, and are responsible for both flexion at the shoulder and the elbow. Since this nerve innervates many of the big flexors of the elbow, oftentimes patients with injury to this nerve will have problems with flexing at the elbow or weakness at the elbow. Next up, let's talk about the sensory innervation of the musculocutaneous nerve. The official name for the nerve is the lateral antebrachial cutaneous nerve, but you're not responsible for knowing the name of the nerve as much as the area that it innervates, which is the lateral forearm. So here we have the anterior and the posterior view of the areas that are innervated by the musculocutaneous nerve. And what you may have noticed is that the sensory innervation of the musculocutaneous nerve is not actually that close to where the muscular motor innervation of the nerve is happening. And the way that I like to think about that is that as the musculocutaneous nerve comes off the brachial plexus, it has all this energy, and so it innervates all of the muscles that are up there, the coracobrachialis, the biceps brachii, the brachialis. But as it moves further and further down the arm, it gets tired and it doesn't want to innervate these big muscles. And so instead, it just settles to do the skin around the area. I use that to help me remember how the musculocutaneous nerve innervates the anterior compartment of the arm, but the lateral part of the forearm. And finally, we'll talk about some causes of injury to the musculocutaneous nerve. Injury to the musculocutaneous nerve usually happens with damage or compression of some part of the brachial plexus. For instance, damage or compression of the upper trunk, which would be right here, leads to a condition known as Erb palsy. This is pretty important and will have its own video, so we won't go into details here, but musculocutaneous nerve is among the nerves injured in that lesion. Additionally, injury in the lateral cord or even further down the line, here or here, might result in more isolated musculocutaneous nerve injury. Common causes of injury that you'll see in a question might be from trauma, from an accident or a dislocation, from lateral flexion of the neck, specifically if there's excessive traction when a baby is being born and they're sort of yanking on its head to pull it out, that can damage the brachial plexus and cause severe nerve damage. Or a tumor from something like a lung cancer can compress the brachial plexus and present with nerve damage. All right, let's do a recap and then we'll do a practice question together. The nerve roots of the musculocutaneous nerve are from C5, C6, and C7. The motor innervation is of muscles in the anterior compartment of the arm, including the coracobrachialis, the biceps brachii, and the brachialis. The sensory innervation of the musculocutaneous nerve is a little bit inferior to those muscles, and it will innervate the lateral aspect of the forearm. Common causes of injury are anything that can damage or compress the brachial plexus. So common things we might see in a question would be trauma, lateral flexion of the neck, or a tumor from a cancer. A practice question might sound something like this. A 33-year-old male presents to your emergency department after an injury while surfing. The patient reports that his surfboard hit him after falling on a wave. Vital signs show a blood pressure of 129/88, an internal temperature of 98.6 degrees Fahrenheit, and a heart rate of 78 beats per minute. On physical examination, you notice a diminished biceps tendon reflex and 3 out of 5 strength with elbow flexion. Which area of his arm might have reduced sensation from the nerve most likely injured in this patient? So in this patient, a diminished biceps tendon reflex and weakness at elbow flexion indicate musculocutaneous nerve damage. And so if we recall, the sensory innervation of the musculocutaneous nerve is going to be the lateral aspect of the forearm. All right, guys, that's all I have for you today. Join us next time as we talk about the axillary nerve, and I'll see you there. Howdy, everybody. My name's Jonathan. Welcome back to your MSK unit. And today we are continuing to talk about one of the terminal branches of the brachial plexus, the axillary nerve. So if you're ready, let's hop into it. Before we get into our slide, I think it's a good idea to go over our brachial plexus roadmap and talk about how we get to the axillary nerve from the nerve roots. So C5 and C6 are going to join together to form the superior trunk. From there, they'll send off a division to the posterior cord, where C5 and C6 will branch off again to form the axillary nerve. As I just mentioned, the nerve roots of the axillary nerve include C5 and C6. I think it's worth mentioning that this does not include the C5-C6 biceps tendon reflex. Even though they share the same roots, the bicep is innervated by the musculocutaneous nerve, not the axillary nerve. So this means that you can have a normal intact biceps tendon reflex even with axillary nerve damage. All right, let's move on and talk about the motor innervation of the axillary nerve. The first muscle we'll talk about will be the teres minor muscle, which is this right here. So the teres minor muscle is going to originate on the lateral aspect of the scapula, and then it's going to insert on what's called the inferior facet of the greater tubercle of the humerus. The important part to note is that the greater tubercle is on the lateral aspect of the humerus. So this teres minor muscle needs to reach around the humerus in order to insert on that inferior facet. So you can imagine that when this muscle contracts, what we're going to have is a rotation of the humerus, and so we will see external rotation of the arm. Additionally, because of the scapula's location, it'll also cause a little bit of adduction of the humerus, pulling it toward the body. And the other muscle that's innervated by the axillary nerve is the deltoid, this muscle here. The deltoid is named after its triangular shape and is often broken down into 3 parts to help distinguish the different origins and actions that the deltoid contributes to. For instance, the anterior part of the deltoid originates on the distal part of the clavicle and then inserts onto the humerus. And so you can imagine flexion of this part of the muscle will flex the arm in front of the body as well as abduct the arm up. In contrast, the posterior part of the deltoid, if this part is contracted, then the arm will extend behind the body in addition to abducting up. The medial part of the deltoid is going to originate on the acromion and then insert onto the humerus and be a big contributor to the abduction of the arm. Together, the parts of the deltoid are going to contract together to abduct the arm at the shoulder when it is greater than 15 degrees. For the first 15 degrees, the supraspinatus, the small muscle in the shoulder girdle, will be the primary abductor of the arm. As we approach and exceed 90 degrees of abduction, other muscles like the serratus anterior and trapezius muscle will contribute to arm abduction. Because the axillary nerve innervates the deltoid, when there's axillary nerve damage, sometimes we can have deltoid muscle wasting. And this leads to something that we call a flattened deltoid. And so this looks exactly what it sounds like. There's a sort of flatness on the side of the shoulder due to atrophy and muscle wasting from axillary nerve damage. All right, let's talk about sensory innervation. So the superior lateral cutaneous nerve will be coming off the axillary nerve to innervate the lower shoulder and lateral arm. And so one way I like to think about this is that the fibers of the deltoid are going to go along and they're going to insert here at the humerus. And so the axillary nerve is going to have to innervate all these fibers, and then it's left here, this spot on the arm, and it goes, well, now what? We've already innervated the deltoid. I might as well innervate the skin while I'm here. And so the area of the skin that's innervated by the axillary nerve is just below the insertion point of the deltoid. All right, and finally, let's go over some causes of injury to the axillary nerve. And something to consider before we talk about specific causes of injury is where is the axillary nerve located? So it's innervating these muscles and the sensory that's very high up in the arm, near the top of the humerus or in the shoulder. And so any damage to the upper humerus or to the shoulder can present with axillary nerve damage. So a common way that there may be axillary nerve damage is with an anterior dislocation of the humerus. Anterior dislocations constitute about 90% of all dislocations of the shoulder. Importantly, let's talk about what an anterior dislocation of the shoulder looks like. So a patient will come in and their injured arm will be externally rotated and abducted away from their torso. Additionally, a fracture at the surgical neck of the humerus, which is up here, can sever or compress the axillary nerve. Like any nerve in the brachial plexus, compression from a tumor or iatrogenic causes can compress or damage the nerve. Specifically, a shoulder surgery, maybe after a dislocation, can damage the axillary nerve. All right, let's do a recap together and then we'll do a practice question. So the nerve roots of the axillary nerve are going to come from C5 and C6, forming the posterior cord and then forming off to the axillary nerve. The muscles innervated by the axillary nerve will be the teres minor, this muscle here, which will reach around the humerus to externally rotate the arm in addition to adduction, and the deltoid, this muscle here, which will work to flex, extend, and importantly, abduct the shoulder above 15 degrees. The sensory innervation of the axillary nerve will be at the lower shoulder and lateral arm around the area where the deltoid inserts into the humerus. And causes of injury include anything that can damage the upper humerus or shoulder, including a dislocation, a fracture at the surgical neck, compression from a tumor, or a surgery mishap. And a practice question might sound something like this. A 75-year-old female presents to the emergency department with intense shoulder pain after a fall. Vital signs include a blood pressure of 139/99, a temperature of 37 degrees Celsius, and a heart rate of 98 beats per minute. On physical exam, the patient has a shoulder that is internally rotated and adducted. X-ray shows anterior dislocation of the shoulder. What are the nerve roots of the nerve that is most likely injured in this patient? So as we discussed earlier, an anterior dislocation of the humerus is a common cause of axillary nerve damage. And if you'll recall back to the beginning of the video, we talked about the nerve roots, which is C5 and C6. All right, y'all, that's everything from me. Good luck studying, and I'll see you next time. Howdy everybody, welcome back to MSK. My name is Jonathan, and today we are going over another terminal branch of the brachial plexus, the radial nerve. Let's hop into it. Alright, to start us off, we're going to go over our brachial plexus roadmap and talk about how we get to the radial nerve from the individual nerve roots. Starting with C5 and C6, they will add together to form the superior trunk, where they will send off a posterior division to the posterior cord, and then add to the radial nerve. C7 will shoot straight across and add to the middle trunk, where it will then add to the posterior cord and to the radial nerve. And lastly, C8 and T1 will form the inferior trunk, where they will send off a posterior division to the posterior cord and complete the radial nerve. So as I just mentioned, the radial nerve roots are going to include C5 through T1, which is every nerve root of the brachial plexus. Alright, moving on to the motor innervation of the radial nerve, we will start with the triceps brachii, this muscle here. The triceps brachii are named for their three heads. The lateral head here in yellow, the long head here in red, and the medial head that's hiding behind them in the green. The lateral head and the medial head will originate on the posterior side of the humerus and then insert on the posterior ulna, making them extenders of the elbow. Importantly, the long head of the triceps will originate on the infraglenoid tubercle of the scapula and then go down to insert onto the ulna with the other two heads of the tricep. What this means is that in addition to contributing to elbow extension, the long head also contributes to shoulder extension and adduction, moving the arm behind the torso and toward the torso. The next muscle we'll talk about is the anconeus. If you look down here with these extensors, it is this muscle right about here. As you can see, the anconeus is a very small muscle, and it helps to attach the humerus and ulna similar to the way that the tricep does. And although the anconeus is active during elbow extension, because of its small size, it contributes very little to this movement. Sorry, anconeus. You're just not that helpful. The next muscle we'll talk about will be the brachialis, this muscle here. Because the brachialis originates on the anterior part of the humerus and then inserts onto the anterior ulna, then this will contribute to flexion of the elbow. Importantly, the brachialis is usually dual innervated along with the musculocutaneous nerve. The radial nerve will innervate the lateral aspect of the muscle, with the musculocutaneous nerve innervating the medial aspect of the muscle. The last muscle, or rather group of muscles that we're going to talk about, is the posterior compartment of the forearm, which includes all of the extensors of the wrist and fingers. Because the extensors will have their own video, and there are way too many for me to list them all here, we'll talk a little bit more about the clinical significance of the extensors and what happens if the radial nerve is injured. Because all of the extensors are innervated by the radial nerve, if we have an injury to this nerve, this can lead to something called wrist drop. And you can imagine what this looks like. If your hand is completely unable to extend the wrist out to a normal position, then it might look something like this. Another interesting clinical feature is that you actually need wrist extension for maximum grip strength. And you can test this out on yourself. If you completely flex your wrist over, stick your fingers inside and squeeze as hard as you can, and you'll find it's not very strong. Extend your wrist and all of a sudden you're back to full strength. What that means is that a question might not tell you that a patient specifically presents with wrist drop. Instead, they might describe that the patient reports having complaints of weakened grip, Maybe they are dropping their items, or maybe they struggle to pick up things. And so you'll remember that because the extensors are necessary for grip strength, that could clue in a radial nerve injury. But a radial injury is not the only nerve injury that can present with weakened grip strength. And so you have to look for other clues to parse out whether you're talking about the radial nerve or the median nerve or the ulnar nerve. And so one of those clues will be any sensory innervation changes in the patient. So let's talk about the sensory innervation of the radial nerve. The radial nerve will cover the dorsal aspect of the arm and forearm in this area here, and it will include the dorsal aspect of the radial hand, and importantly, 3.5 fingers on the radial side. The radial nerve will innervate fingers 1, 2, 3, but will split this fourth finger here with the ulnar nerve. Also important to note is that the very fingertips are innervated by the median nerve, not the radial nerve. And let's talk a little bit about naming conventions. So the posterior side of the hand is called the dorsal side or the dorsum of the hand, and the anterior side of the hand is called the palmar surface, or sometimes called the volar surface. And so the radial nerve will be mostly responsible for the dorsum radial part of the hand. And lastly, we'll talk about causes of injury to the radial nerve. The nerve can be injured by a fracture at the mid-shaft of the humerus, or compression of the axilla, maybe excessive use of crutches, or in a funny sleeping position. If you can imagine someone going out and having a little too much to drink on their Saturday night, and they forget to take themselves to a bed, and instead they just sleep in the chair that they're in with their arm hung over the side of the chair. This can put a lot of compression on the armpit, leading to radial nerve injury, as a condition called Saturday night palsy. And lastly, excessive supination and pronation of the wrist. Maybe in a question stem, this will be a carpenter who's using a screwdriver a lot. This can irritate the radial nerve and cause injury. Something important to think about for the radial nerve, especially when it comes to questions, is that it can have very variable presentations because of how long the area of innervation is. The radial nerve innervates muscles in the posterior arm, posterior forearm, and sensation in the dorsum of the hand. What this means is that there's variable presentation based off of the location of the injury. So let's talk about how nerve branches innervate distally, and then we'll go back and talk about what this means for the variable presentations for radial nerve injury. So here we have our humerus and we have our tricep. And running down the arm, I will add our radial nerve. Now coming off of that radial nerve will be the branches that go to innervate our muscle and skin. And so here we'll have our branches that lead to the tricep, and down here maybe these branches will lead to the posterior forearm. And what you'll see is that when this terminal branch comes off the radial nerve, it will travel distally down the arm before reaching its target muscle. So in the case of a midshaft fracture, we may sever the radial nerve at this level. But because the branches for the tricep have already branched off before traveling distally to reach the tricep, tricep function may be spared in a midshaft fracture. And instead, the downstream nerves, maybe to the posterior forearm, will be predominantly affected instead. And so here I've drawn the radial nerve coming down and around the arm to innervate the posterior forearm. You can see it's the posterior because the arm is pronated here. And you can see coming off that main nerve are the beginning of branches that will go to innervate the muscles and skin that the radial nerve innervates. And so the branch of the tricep will come off that radial nerve and then travel distally before innervating the muscle fibers of the arm. So even in the event of a midshaft fracture that severs that radial nerve right there, that tricep head that's already come off can still come down and innervate the three heads of the tricep. So let's go over our causes of injury and what their presentations might look like. So as I said, because nerves innervate distally, even in a midshaft fracture of the humerus, tricep function and sensation at the back of the arm may be spared, and a patient will present with injury distal to that. They may have wrist drop, weak grip, loss of sensation on the forearm and dorsum of the hand. Compare that with a patient who has radial nerve damage from compression of the axilla in the case of Saturday night palsy. This patient may have a loss of sensation in the entire posterior arm, forearm, and dorsum of the hand, in addition to weakness with elbow extension and extension of the fingers and wrist. A patient who injures their radial nerve from excessive supination and pronation of the wrist, probably somewhere in the forearm, will probably only present with minor motor deficits, such as an inability to extend the fingers, leading to finger drop. Alright, we just went over a lot, so let's do a recap and then we'll do a practice question together. The nerve roots of the radial nerve will be all the nerve roots of the brachial plexus, C5 through T1. The motor innervation of the radial nerve will include the triceps and anconeus, which will help with elbow extension, in addition to the triceps contributing to shoulder extension and abduction. The brachialis will be shared with the musculocutaneous nerve and will contribute to flexion at the elbow, and the posterior compartment of the forearm, which will house the extensors of the hand and wrist. The sensory innervation of the radial nerve will include the dorsal aspect of the arm and forearm and the dorsum of the hand on the radial 3.5 fingers. And common causes of injury will be a midshaft fracture, compression of the axilla, and excessive pronation and supination, all at the wrist. And the site of injury is important for the presentation, with everything below the site of injury being affected in the radial nerve. A practice question might sound something like this. A 55-year-old male presents to your emergency department after a motor vehicle accident. The patient reports decreased sensation in the back of the hand and wrist, in addition to difficulty extending his fingers. Vital signs include a blood pressure of 135/91, a temperature of 38 degrees Celsius, and a heart rate of 99 beats per minute. On physical exam, the patient has reduced sensation on the radial dorsum of the hand and 1 out of 5 strength with wrist extension. Imaging shows a transverse fracture of the patient's humerus. Assuming the nerve damage is from the fracture, what is the most likely location of the fracture on the patient's humerus? So this patient will present with loss of sensation on the dorsum of the hand, in addition to weak extension of the wrist, which will be indicative of a radial nerve injury. And the most common location of a humerus fracture causing radial nerve injury is at the mid shaft of the humerus. Alright guys, that's everything from me today. Thanks for watching, and I'll see you next time. Howdy everybody, welcome back to MSK. My name is Jonathan. Today we are continuing to go over the terminal branches of the brachial plexus, and we will be talking about the median nerve. Let's get into it. Alright, we're going to start with our roadmap of the brachial plexus and walk through how we get to the median nerve from the individual nerve root. C5 and C6 will join together to form the superior trunk, where they will move on to form the lateral cord. C7 will form the middle trunk and then make an anterior division to join the lateral cord, which will then go on to form one part of the median nerve. C8 and T1 will join together to form the inferior trunk, where they will continue on to form the medial cord and complete the median nerve. So as we just discussed, the nerve roots of the median nerve will include C5 to T1, which is all the nerve roots of the brachial plexus. Alright, let's move on and talk about the motor innervation of the median nerve. The median nerve will innervate most flexors of the forearm, which are these group of muscles down here. Importantly, this has two exceptions. The first exception is the flexor carpi ulnaris, this muscle marked out here in red. As the name suggests, this muscle is innervated by the ulnar nerve, not the median nerve. The second exception is the ulnar side of the flexor digitorum profundus. As the name suggests, the flexor digitorum profundus will flex each of the fingers excluding the thumb. So, there will be a tendon that goes down to reach each finger. The lateral or the radial side will be innervated by the median nerve, while the medial or the ulnar side will be innervated by the ulnar nerve. So again, most flexors of the forearm are innervated by the median nerve, with the exception of the flexor carpi ulnaris and the ulnar side of the flexor digitorum profundus. As the name implies, these will be responsible for wrist and finger flexion. Additionally, the median nerve is responsible for innervation of the first and second lumbricals of the hand. The lumbricals are these worm-like muscles in the hand, and similar to the flexor digitorum profundus, will be split innervated between the median nerve and the ulnar nerve. The median nerve will innervate lumbricals 1 and 2, located here on the radial side of the hand, and the ulnar nerve will innervate lumbricals 3 and 4 here on the ulnar side of the hand. The action of the lumbricals is to flex at the metacarpophalangeal joint here, and to extend at the proximal and distal interphalangeal joints up here. So if it's lumbricals day at the gym, what are you going to do? So we'll start with a relaxed hand. And first I will extend at the distal and proximal interphalangeal joints, and then I will flex at the metacarpophalangeal joints, leaving me with this shape of a hand. Now here I am using all of my lumbricals, but remember the median nerve only innervates the first 2 lumbricals, so it will only cause this action. Injury to these lumbricals of the median nerve can lead to something called hand of benediction. This hand distortion will have its own video, but I'll go over it briefly here. If a patient comes in with median nerve injury and their first 2 lumbricals won't work, when you ask them to make a fist, they'll be able to flex the metacarpophalangeal joints at the outer 2 because that's innervated by the ulnar nerve, but not these 2 fingers. leaving them with something that we call the hand of benediction or Pope's blessing. You're blessed. And lastly, the median nerve is going to innervate the thenar muscles of the hand. The thenar compartment is the group of muscles at the base of the thumb down here and will assist with the fine motor movements of the thumb. So we'll have abduction, which will be coming from the abductor pollicis brevis. An abduction of the thumb will move the thumb away from the fingers. You have abduction, as well as flexion, which will come from the flexor pollicis brevis. Importantly, the flexor pollicis brevis has dual innervation, with the superficial head innervated by the median nerve, but the deep head innervated by the ulnar nerve. Flexion of the thumb will be moving it across the hand, so we have flexion. And we have opposition of the thumb, the action of opponens pollicis. And opposition will be touching the finger pads of the thumb to the finger pads of the other fingers. And even though it's on here, the adductor pollicis will be innervated by the ulnar nerve, not the median nerve. A helpful mnemonic for some students is all for one and one for all, which shows the intrinsic muscles of the hand from lateral to medial. So to reiterate, most of the thenar eminence will be innervated by the median nerve, with the exception of that deep head of the flexor pollicis brevis. And the hypothenar complex and adductor pollicis brevis will be innervated by the ulnar nerve. Injury to the median nerve and loss of these thenar muscles can lead to ape hand. Ape hand is the inability to abduct the thumb away from the hand, leaving it stuck to the palm. Next up, we'll talk about the sensory innervation of the median nerve. The palmar cutaneous branch of the median nerve will innervate the lateral aspect of the palm, this area here. Importantly, although the median nerve travels through the carpal tunnel in order to innervate the fingers and the thenar eminence, the palmar cutaneous branch does not go through the carpal tunnel. It branches off of the median nerve before going into the wrist and thus goes over the carpal tunnel. The significance of this is that in carpal tunnel syndrome, which is compression through the carpal tunnel, the palm of the hand is often spared of the tingling and numbness that the fingers experience. In contrast, the digital cutaneous branches will go through that carpal tunnel, which innervate the palmar side and lateral 3.5 digits and fingertips. So the palmar or volar side of digits 1, 2, 3, and half of this. And what is the other nerve that's been sharing everything in the hand and forearm with the median nerve? That's right, the ulnar nerve will get the rest of the sensory innervation of the palmar side of the hand. Because the digital cutaneous branches will branch from the median nerve after it goes through the carpal tunnel, if there's compression in the carpal tunnel, there may be numbness and tingling in these 3.5 fingers, but possibly not in the palmar aspect of the hand. And lastly, we'll go over some causes of injury to the median nerve. One potential cause of median nerve injury would be a fracture of the humerus, specifically a supracondylar fracture, which is very common in pediatric patients if they fall on an outstretched hand. Additionally, any type of trauma, such as a laceration or penetrating injury from a stab wound or a gunshot, can injure the median nerve. Compression can also cause median nerve injury. Very commonly, carpal tunnel syndrome can affect those who are doing repetitive, fine motor movements that involve the wrist. This may be the case in a patient that types a lot at work, or maybe they just play too many video games without any wrist support. And finally, there can be compression from a tumor, such as a schwannoma, which is typically found in older patients. All right, let's go over a recap and then we'll do a practice question together. The nerve roots of the median nerve will include C5 to T1, which is all of the nerve roots of the brachial plexus. For the motor innervation of the median nerve, with the exception of flexor carpi ulnaris and the ulnar side of flexor digitorum profundus, the median nerve will innervate most flexors of the forearm, which will contribute to wrist and finger flexion. Additionally, the first and second lumbricals will be innervated by the median nerve, as well as the thenar muscles of the hand, contributing to the fine motor movements of abduction, flexion, and opposition of the thumb. The sensory innervation of the median nerve includes the palmar cutaneous branch, which will cover the lateral aspect of the palm, and the digital cutaneous branch, which will cover the fingers and fingertips. Common causes of injury may include a supracondylar fracture of the humerus, or a laceration from a traumatic injury, or compression, which can come from a tumor, or very commonly in carpal tunnel syndrome, which can come with tingling and numbness in the fingers, but because that palmar cutaneous branch branches off the median nerve before going in the carpal tunnel, the palm may be spared in carpal tunnel syndrome. A practice question might sound something like this. A 6-year-old male presents to your emergency department with left-sided arm pain after falling off a trampoline. The patient's mother reports seeing him try to catch his fall with his arms and thinks he may have broken his arm in the process. Vital signs include a blood pressure of 134/85, internal temperature of 36.8, and a heart rate of 98 beats per minute. On physical exam, you notice the patient has reduced sensation on the radial palmar side of the hand and 3 fingers, and 2 out of 5 strength with wrist flexion. Imaging shows a supracondylar fracture of the humerus. If left untreated, what area of the hand would be most likely to show muscle wasting given time? So as we mentioned earlier, a supracondylar fracture is a common cause of median nerve injury, especially in pediatric patients. And because this patient comes in with reduced sensation on the radial palmar side of the hand, in addition to weak wrist flexion, we can infer that there's median nerve damage. And so what area of the hand is innervated by the median nerve is the thenar muscles. So we will see wasting in the thenar eminence of the hand over time if left untreated. All right, guys, that's everything from me today. Thanks for watching. Good luck studying, and I'll see you next time. Howdy, everybody. Welcome back to MSK. My name is Jonathan, and today we are going over another terminal branch of the brachial plexus, the ulnar nerve. Let's hop into it. So let's start with our brachial plexus roadmap and discuss how we get to the ulnar nerve from the nerve roots. We're going to have C8 and T1 join together to form the inferior trunk, which will then go onward to become the medial cord and thus contribute to the ulnar nerve. So as we just went over, the nerve roots for the ulnar nerve are not too complicated, as we have C8 and T1 leading into the ulnar nerve. All right, let's move on and talk about the motor innervation of the ulnar nerve. We'll start with the flexor carpi ulnaris, or the FCU, as I have it written here. And this muscle will be a flexor of the forearm and shown here marked out in red. The flexor carpi ulnaris will have an origin on the medial epicondyle of the humerus, as well as the proximal part of the ulna. The FCU will then go down the medial side of the forearm and insert onto the bones of the hand, the pisiform and hamate, in addition to the base of the 5th metacarpal bone. Because the FCU crosses the wrist joint in front, we know that it will contribute to wrist flexion, and because it is so medial, it will contribute to wrist adduction in addition to flexion. So because the FCU will be on the ulnar side of the forearm, it will contribute to wrist flexion and wrist adduction. Additionally, the ulnar nerve will innervate the medial half of the flexor digitorum profundus. And so recall that the flexor digitorum profundus is a flexor that will send a tendon to the distal phalange of the forefingers, excluding the thumb. And so the medial or the ulnar side of this muscle, the flexor digitorum profundus, will be innervated by the ulnar nerve, while the lateral side of the flexor digitorum profundus will be innervated by the median nerve, which I'll represent here with blue. And so because the FDP will insert all the way onto the distal phalanges, it will contribute to flexion of the 4th and 5th digits innervated by the ulnar nerve. And lastly, the ulnar nerve will innervate the intrinsic muscles of the hand that are not innervated by the median nerve. So the hand will have its own chapter, but let's briefly go over some of the muscles and innervations so that we can parse out the differences between median and ulnar nerve. So the median nerve will be predominantly responsible for the thenar compartment, including abductor pollicis, flexor pollicis brevis, and opponens pollicis brevis. The caveat to this is that the flexor pollicis brevis has a superficial head innervated by the median nerve, but the deep head is innervated by the ulnar nerve. The ulnar nerve will be responsible for the rest of this mnemonic, with the adductor pollicis brevis, opponens digiti minimi, flexor digiti minimi, and abductor digiti minimi. While we're here, let's talk a little bit about the action of some of the muscles innervated by the ulnar nerve. Adductor pollicis brevis will contribute to thumb adduction, a motion that looks like this. So we're going to adduct the thumb closer to the palm of the hand. Opponens digiti minimi will assist with opposition of the pinky finger, the motion of bringing the pinky and thumb together, or alone the pinky moving across the hand. Flexor digiti minimi will help with flexion of the pinky, a motion that looks like this, flexing the pinky down. And abductor digiti minimi, as you can guess, abducts the pinky away from the other fingers, a motion that would be like this, abduct away, abduct away. Here, I'll also talk briefly about the lumbricals, which is another group of muscles split by the ulnar and median nerve. The first two lumbricals will be innervated by the median nerve, while the third and fourth lumbricals will be innervated by the ulnar nerve. And as a reminder, the lumbricals will cause extension at the proximal and distal interphalangeal joints and flexion at the metacarpal phalangeal joints, leading us with this. But recall, only the third and fourth lumbricals will be innervated by the ulnar nerve. That might look like this. In addition to the hypothenar and thenar compartments of the hand, there are also the palmar and dorsal interosseous muscles, both of which are innervated by the ulnar nerve. Down here, we have our dorsal interossei muscles, which will be responsible for abduction of the fingers. So our fingers will abduct away from the midline. Also innervated by the ulnar nerve are the palmar interossei muscles, which will adduct the fingers back together. Adduction, abduction, adduction. And so in this image here, we'll have the opponens digiti minimi and adductor pollicis innervated by the ulnar nerve, with the opponens pollicis and abductor pollicis brevis innervated by the median nerve, and the flexor pollicis brevis with dual innervation. And I will also briefly mention that because the ulnar nerve innervates the third and fourth lumbricals, distal injury to the ulnar nerve, which impairs those lumbricals, can lead to something called ulnar claw. So if a patient comes in with ulnar nerve injury in their hands at rest and we ask them to extend their fingers, the lumbricals acting at this joint won't be able to extend the fingers, only the other two. And so the patient will look something like this after being asked to extend all of their fingers from a closed fist. All right, let's move on and talk about the sensory innervation of the ulnar nerve. This innervation is pretty straightforward as it covers the medial hand and 1.5 digits, including both the palmar and dorsal aspect. And so down here we can see that the ring finger will be split down the middle, while the pinky and medial hand will be innervated by the ulnar nerve. All right, and finally, let's talk about causes of injury to the ulnar nerve. One potential cause of ulnar nerve injury would be a fracture at the hook of hamate, which is one of the bones in the hand. This can happen from a patient falling on an outstretched hand. It can also happen in athletes that are playing a sport that requires gripping something, either hockey or baseball or golf. As when you're holding an object, it can put pressure on the hamate and a traumatic incident can cause a fracture there. Additionally, ulnar nerve damage can be caused by a fracture at the medial epicondyle of the humerus. This is typically found in children, often from a traumatic incident of playing sports. And finally, compression of the nerve can lead to damage. So as the ulnar nerve goes to enter the hand to innervate some of the muscles and sensory innervation, it will pass through what's known as the tunnel of Guyan, or Guyan canal. If there's chronic compression through that canal, that can lead to Guyan canal syndrome, something we often see in bikers as they're resting their hand on their handlebars for long periods of time. Additionally, there can be compression in the cubital tunnel of the elbow. This would lead to cubital tunnel syndrome and might be the result of leaning on your elbow for long periods of time or a traumatic blow to the elbow. And lastly, there can be compression from any sort of growth or a tumor, or very often a ganglion cyst, which we would see in older patients. All right, we went over a lot, so let's recap and then we'll do a practice question together. The nerve roots of the ulnar nerve are going to start from C8 and T1 to form the inferior trunk and then go on to form the ulnar nerve. The motor innervation of the ulnar nerve will include the FCU, the flexor carpi ulnaris, in addition to the medial half of the flexor digitorum profundus, and the intrinsic muscles of the hand that are not innervated by the median nerve. This will include the dorsal and palmar interosseous muscles, in addition to the third and fourth lumbricals, the hypothenar compartment, the adductor pollicis brevis, and palmaris brevis, a weak flexor of the wrist. The sensory innervation of the ulnar nerve will include the medial hand and 1.5 digits, and causes of injury can include a fracture of the hook of hamate or fracture at the medial epicondyle of the humerus, or compression of the nerve, either through the Guyan canal, the cubital tunnel, or anywhere along the ulnar nerve from a cyst or tumor. And a practice question might sound something like this. A 34-year-old male presents to the primary care clinic with 1 week of new onset left-handed weakness. The patient denies trauma, but reports that symptoms worsen when holding his cell phone up to his ear for a long call, or when resting his elbow on his office chair for extended periods of time. The patient's vital signs are within normal limits, and he reports that he is otherwise healthy. On physical exam, the patient has reduced sensation in the fourth and fifth digits in addition to 4 out of 5 grip strength in the left hand. Which anatomical structure is most likely compressing the nerve leading to this patient's symptoms? Because we see reduced sensation in those 4th and 5th fingers, in addition to weakened grip strength, we suspect that there's ulnar nerve damage. And because this patient has worsening symptoms with flexion of his elbow or resting on his elbow, we can assume that there's compression in the cubital tunnel of this patient. If it instead had been compression in the K.A.N tunnel, there would be more indication as to why there's compression on his wrist. Maybe he's a biker, maybe he's a construction worker who works with a jackhammer. But because his symptoms are worsened by actions at the cubital tunnel, we suspect cubital tunnel syndrome. All right, that's everything from me today. Thanks for watching. I'll see you next time, and good luck studying. Howdy everybody, welcome back to MSK. My name is Jonathan, and today we are continuing our adventure of the brachial plexus, and we will be talking about the pathology Erb palsy. Let's hop into it. The pathophysiology of Erb palsy will be injury to the upper trunk, which is traditionally C5 and C6. For the purposes of step 1, you can consider Erb palsy to be pretty strictly to the C5-C6 upper trunk. Just know that in the real world, this can include other nerve roots like C7 or even C3-C4. Okay, let's take a look at our brachial plexus roadmap and see how an upper trunk injury affects the downstream nerves. So let's say that we have our injury right here on the upper trunk. Following our roadmap here, we can see that the suprascapular nerve would be heavily affected, as is our axillary nerve if we follow this posterior division, the posterior cord. The axillary nerve shares its roots, C5 and C6, with the upper trunk. And if we go down our lateral cord, we will see that the musculocutaneous nerve is also heavily affected by Erb palsy. Additionally, as it shares the posterior cord with the axillary nerve, the radial nerve will also be affected. And you may be thinking, now wait a minute, there's all kinds of nerves that are innervated by C5, C6. Why aren't those all messed up? And you're right, there are nerves like the median nerve that do receive some innervation from C5, C6. But the contribution of each nerve root to the final nerve is not uniform. So classically, we don't consider Erb palsy to also affect the median nerve or the lower subscapular nerve. Predominantly, we think musculocutaneous, axillary, suprascapular, and the radial. So to reiterate, the primary affected nerves will be the musculocutaneous, axillary, radial, and suprascapular. All right, let's move on and talk causes. How do we get Erb's palsy? The answer to that question will depend on the age of our patient. In infants, it's typically going to be a birth injury from excessive lateral flexion of the neck. So a traumatic pulling of the head away from the affected shoulder can stretch the nerve and cause damage. So this can happen when there is excessive lateral traction in an otherwise normal delivery. Erb palsy can also be a complication from an obstetric emergency known as shoulder dystocia. This happens after a baby's head is delivered. The shoulder can be caught behind the pubic symphysis of the mother. Some of the maneuvers used to get that infant out of the mother may lead to that lateral traction that causes Erb palsy. If there's adult onset Erb palsy, this will typically be from a traumatic injury. If a patient were to fall on their head and shoulder from a motor vehicle accident, maybe they were riding a motorcycle or maybe they weren't wearing their seatbelt, wear your seatbelts kids, and then falling on their head causes lateral traction, pulling their head away from the affected shoulder. Additionally, there can be damage or compression to the upper trunk from a dislocation of the humerus or a fracture at the humerus or clavicle. This might be more typical for a sports injury or falling off a trampoline while playing dodgeball at a trampoline park, something like that. And remember that location of the fracture on the arm will be a relevant clue in trying to figure out what kind of pathology you're talking about. For the case of Erb palsy, the fracture would need to be pretty high up on the arm. Something like a mid-shaft fracture would be more classical for a radial nerve injury. All right, let's move on and talk about the very important presentation of Erb palsy. What does it look like when a patient has this condition? So I think it's really important to understand how motor nerve damage leads to the presentation. So understand that at all times, the muscles in your body are all a little bit active. And so even while you're at rest, at all times, there's a balance between almost every joint in the body and its actions, a balance between flexion and extension, a balance between abduction and adduction. And so when there's motor nerve damage and we lose one side of that balance, and the patient will present with the non-impaired action of that balance. Let's use an example. In Erb palsy, the patients will have AD adduction of the arm. So the arm will be held close to the body. This is because there will be impaired AB abduction by the deltoid, which is innervated by the axillary nerve. So normally there's a balance between abduction and adduction at the shoulder. But when motor nerve damage impairs the deltoid, only adduction is left, and so the patient will have their arm adducted to their torso. Additionally, patients will present with flexion of the wrist. This is because the extension by the posterior forearm is impaired from the radial nerve, and so the flexion of the wrist predominates. There will be pronation of the forearm and extension of the elbow because the biceps brachii from the musculocutaneous nerve will be impaired. And finally, there will be medial or internal rotation of the arm from the infraspinatus and supraspinatus by the suprascapular nerve. But as long as you know that these are the affective nerves, you can deduce what the presentation would look like in a patient. If I know the musculocutaneous nerve is affected, then I know that the biceps brachii will be affected, and I know that supination and flexion of the elbow are going to be gone or reduced. And so the patient will present with the opposite of that. They will have forearm extension and pronation. So if we can understand the nerve anatomy, then the presentation makes sense. In infants, there will also be a reduced Moro reflex. Based off of the motor deficits that we've talked about, can you guess what are the possible motions that might be, even if you haven't heard of the Moro reflex? So the Moro reflex, or sometimes called the startle reflex, is when you make a loud noise, or if you gaslight the baby into thinking you're about to drop it by suddenly lowering its head, it will abduct and extend its arms up, similar to the way you're going down a roller coaster. But as we already discussed, abduction by the deltoid is impaired in a patient with Erb palsy. And so in an infant with Erb palsy, the affected side won't have that arm abduct up with the Moro reflex. And lastly, we'll see a reduced sensation in the C5, C6 dermatomes, which will be this anterior area of the forearm, arm, and thumb. Which brings us to our mnemonic. Erb gets dibs on tips. So in this mnemonic, Erb, our very selfish waiter, representative for Erb palsy, will get DIBS, an acronym for our affected muscles, D for the deltoid, I for the infraspinatus, B for the biceps brachii, and S for the supraspinatus on tips, because Erb palsy presentation is often referred to as waiter's tip. And lastly, let's go over treatment of this condition. Because Erb palsy will leave the patient with medial internal rotation of the arm and extension at the elbow, we're going to immobilize it in the opposite position, with flexion at the elbow and external rotation of the arm. Immobilizing in this position will help reduce the stiffness in the active muscles and strengthen the weakened muscles. Physical therapy will also be very important for strengthening weakened muscles, especially for infants, and if very severe, surgery may be necessary. All right, let's do a recap and then we'll do a practice question together. Erb palsy will affect the upper trunk, which is classically C5 and C6, and will affect the musculocutaneous, axillary radial, and suprascapular nerves. The cause of Erb palsy will be dependent on the age of the affected patient. If the patient is an infant, it's most likely from excessive lateral traction during delivery. If the patient is an adult, it's more likely a traumatic incident from a motor vehicle accident, a fall, dislocation, or fracture. The presentation of Erb palsy often gets referred to as waiter's tip sign, with adduction of the arm, flexion of the wrist, pronation of the forearm, extension of the elbow, and medial rotation of the arm, with reduced Moro reflex in infants because that motion involves abduction of the arm, and loss of sensation in the C5, C6 dermatomes. Treatment is about strengthening the weakened muscles and reducing stiffness in the active ones with immobilization, physical therapy, or if very severe damage to the nerve has happened, surgery may be necessary. A practice question might sound something like this. A G2P2 woman gives birth to a boy at 42 weeks gestational age via vaginal delivery. The birthing process was complicated by shoulder dystocia, which eventually required a forceps delivery. The child's APGAR scores were 7 and 9 at 1 and 5 minutes respectively, and the child's birth weight is 9 pounds 6 ounces with vital signs within normal limits. On physical exam, you notice elbow extension and forearm pronation, in addition to a reduced Moro reflex. What additional motor deficits are also likely to be found in the patient's affected arm? Alright, in this patient there was the reduced Moro reflex in addition to adduction of the arm and pronation of the forearm and extension at the elbow. So the question of what additional motor deficits are most likely would be flexion of the wrist or medial internal rotation of the arm. Alright guys, that's everything from me today. Thanks for watching, good luck studying, and I'll see you next time. Howdy everybody, welcome back to MSK. My name is Jonathan and today we are continuing to go over another pathology of the brachial plexus, Klumpke palsy. Let's hop into it. Starting with the pathophysiology, Clumsy palsy is usually defined as the injury to the lower trunk, which is traditionally C8 and T1. Alright, so let's take a closer look at the brachial plexus and see how an injury here at the inferior or the lower trunk will affect the downstream nerves. So if we follow our injury down the medial cord, we will see that the ulnar nerve, which shares its roots C8 and T1, will be primarily affected. In addition, the median nerve gets much of its innervation from C8, T1, and we may also see deficits in something like the medial pectoral nerve. By now you recognize that the median nerve is not just innervated from C8, T1, but from all of the nerve roots of the brachial plexus. But recall that nerve roots' contribution to the final nerve is not uniform. And so in the case of lower trunk injury, in the case of clumsy palsy, we see motor deficits in the hand of muscles that we know to be innervated by the median nerve. So to reiterate, we will predominantly affect the ulnar and median nerve in the case of lower trunk injury. All right, let's move on and talk about causes. So similar to herb palsy, the cause of this injury is likely to be dependent on the age of your patient. So in infants, it's almost always going to be from a birth injury, specifically upward traction from delivery. So if there's an excessive amount of abduction of the arm, pulling it up and behind the head, then that can stretch the nerve and cause damage. This excessive upward traction and hyperabduction can also be caused during shoulder dystocia. This is an obstetric emergency in which the baby's shoulder gets caught behind the mother's pubic symphysis. The different maneuvers and movements trying to free the baby from this position can cause the damage and lead to clumsy palsy. Importantly, this is more likely to cause herb palsy. So just because a question mentions shoulder dystocia doesn't mean we can definitively assume that it is herb palsy or clumsy palsy. We'll have to look at the rest of the clues in the question to figure out what's going wrong with the patient. In an adult, this injury is more likely to be from a traumatic injury or chronic compression. Similar to the birth injury, the types of trauma that will lead to clumsy palsy are likely to be hyperabduction of the arm. And so an example might be somebody falling out of a tree and trying to catch a branch in order to break their fall. So they'll reach out and grab that branch, but continue to fall past it. And as they do, that branch will pull their arm and hyperabduct it and extend it behind their head and cause an injury to the lower trunk. The injury also does not need to be from trauma. There can be chronic compression through a pancreas tumor, which is a tumor of the lung, or a cervical rib. So normally you have ribs coming out of your thoracic vertebrae starting at T1, but about 1%, maybe a little less of the population actually has a cervical rib coming out of C7. And though it's usually asymptomatic and people don't know until they have an x-ray, it can compress nearby structures. In the event that the cervical rib does compress or damage the lower trunk, then we can have clumsy palsy. If it also is compressing or damaging other structures like the subclavian vein or the subclavian artery, then we can have something known as thoracic outlet syndrome, which will have its own video. Clumsy palsy and thoracic outlet syndrome have overlapping presentation. And so the important distinction between them is that clumsy palsy is generally pretty specific to just nerve damage. Because thoracic outlet syndrome can also compress the vessels of the arm, we see additional signs like pulselessness or swelling of the affected arm. So let's move on and talk about the details of presentation in clumsy palsy. So in contrast to herb palsy, which affected almost the entirety of the arm, with the shoulder and the elbow and the wrist all affected, clumsy palsy will be mostly isolated to motor deficits in the hand. And this is because the intrinsic muscles of the hand are innervated by the ulnar and median nerve, which are affected by that lower trunk injury. In the case that we lose the strength of those intrinsic muscles of the hand, we are left with flexion at the proximal and distal interphalangeal joints and extension at the metacarpal phalangeal joints, leaving us with a total claw hand, as we can see in this picture down here. So if we think about the intrinsic muscles of the hand, that is including the thenar compartment, the hypothenar compartment, adductor pollicis brevis, the palmar and dorsal interossei muscles, and very importantly, the lumbricals. And now these lumbricals are going to help us out because they are dual innervated, with the medial side being innervated by the ulnar nerve and the lateral side being innervated by the median nerve. And that's very helpful for us in helping to determine where the lesion in this patient most likely is based on their presentation. When there's ulnar nerve damage, we see that the lumbricals on the medial side are not working well. When there's median nerve damage, we see that the lateral lumbricals are not working well. But in clumsy palsy, because it's on that lower trunk and it's higher up in the brachial plexus, we see that all of the lumbricals are affected. And so we see total claw hand. And that's one way we can help distinguish this between other nerve pathologies. Additionally, there's reduced grasp reflex in infants. So in an infant, if you place something in the palm of their hand, they will instinctively close their fingers and grasp that object. But obviously, if the affected muscles of the hand that are contributing to that grip are reduced, then the infant will not have that same strength or speed of reflex on the affected side. We are also going to see a decrease in sensation of the C8 and T1 dermatomes, which will be the medial forearm and medial two fingers. Additionally, a patient with clumsy palsy may also have Horner syndrome, which is a triad of miosis, excessive contraction of the pupil, ptosis, drooping of the eyelid, and anhidrosis, which is a lack of the ability to sweat. And so you may be thinking that this is kind of an oddball. All of a sudden we're talking about eyelids when before we were just talking about muscles of the hand. But the relationship between Horner syndrome and clumsy palsy is not that lower injury leads to Horner syndrome, but rather that they often have the same cause. A Pancoast tumor and cervical rib can lead to clumsy palsy and also to Horner syndrome. This is important to note because questions will often ask you not just about what a patient has, but what they could have or what they could have a risk for. So if a question describes a patient with clumsy palsy and suggests that it may be from a Pancoast tumor or a cervical rib, you should be keeping in your mind that Horner syndrome is an additional possible finding in this patient. And lastly, we will go over the treatment of clumsy palsy. Similar to palsy, splinting will be a part of the treatment process, and so we can splint the affected hand for proper alignment. So in order to counteract the claw hand, the fingers may be kept in extension. Additionally, physical therapy will be necessary to strengthen the weakened muscles, and if very severe, surgery will be needed. And it is always worth mentioning that the most fundamental way of treating something where you understand the underlying cause is to address that underlying cause. So in the event that we have clumsy palsy from a Pancoast tumor or a cervical rib, then surgery to remove that underlying cause will be the primary objective of treatment. All right, let's do a recap and then we'll do a short practice question together. Clumsy palsy is defined as injury to the lower trunk, which is classically defined as C8 and T1 and will affect the ulnar and median nerve. The cause in infants is traditionally upward traction from a birth injury, and the cause in adults can either be from trauma or from compression of a structure like a Pancoast tumor or a cervical rib. The presentation of clumsy palsy will be total claw hand, which will be extension at the metacarpal phalangeal joints and flexion at the proximal and distal interphalangeal joints. There will be a reduced grasp reflex in infants from the weakened hand muscles and a decrease in sensation of the C8 and T1 dermatomes on the medial side of the hand and arm. Important to keep in mind, if the cause of that clumsy palsy was a Pancoast tumor or cervical rib, Horner syndrome may also be an additional finding in that patient. And treatment for clumsy palsy will include splinting of the hand, physical therapy, and surgery to either fix the nerve or address the underlying cause. A practice question might sound something like this. A 14-year-old male presents to your clinic with shooting right arm pain after an incident in the bouncy house. The patient reports that his hand was caught on the side netting with his arms raised when attempting a flip. Vital signs are within normal limits. On physical exam, you notice that the patient's proximal and distal interphalangeal joints are flexed, but there's extension at the metacarpal phalangeal joint. The two questions I have for you is what area of the affected arm are we most likely to see reduced sensation? And is this patient at an increased risk for having Horner syndrome? So at this birthday party celebration gone wrong, the patient describes a traumatic incident in which there was hyperabduction of the arm, as their arm was raised when it was caught on the side of the net. Additionally, the physical exam shows total claw hand, and so we suspect lower trunk injury from trauma. So the area of the affected arm with reduced sensation will be the medial arm and medial two fingers, and because this patient presents with an injury to the lower trunk from trauma and not from compression from a cervical rib or Pancoast tumor, we wouldn't consider this patient to be at an increased risk for Horner syndrome, especially considering their young age. Alright guys, that's everything from me. Thanks for watching, good luck studying, and I'll see you next time. Howdy everybody, welcome back to MSK. My name is Jonathan, and today we are continuing to go over more pathology of the brachial plexus, and we will be going over thoracic outlet syndrome. Let's hop into it. So thoracic outlet syndrome, similar to clumsy palsy, will be compression of the lower trunk. So going down our medial cord, we will know that the ulnar nerve will be primarily affected, in addition to the median nerve, which is very similar to clumsy palsy. So as I just went over in the pathophysiology of thoracic outlet syndrome, there will be compression of the lower trunk, which is classically C8 and T1. What makes thoracic outlet syndrome unique compared to some of the other brachial plexus lesions we've discussed is that in addition to nerve damage, there can be compression of the subclavian arteries or subclavian veins. This syndrome gets its name from the area where the compression is usually happening, down here in the thoracic outlet, or more specifically in what's called the scalene triangle. So if we look at our scalene triangle here, let's go over some of the structures that we see. Although it's cut away in this image for clarity, the clavicle will run across here and make the inferior border of the triangle. Below that, we can see the first rib and costal cartilage attaching to the manubrium, and that clavicle and rib are going to make that thoracic outlet. Importantly, the subclavian vessels and brachial plexus will run under that clavicle, but over the first rib. The medial and lateral sides of the scalene triangle will be made up of the anterior and the middle scalene respectively. And so like a lot of parts in the human body, there's not a lot of excess space. And so these vessels and nerves are at risk of compression if there's any abnormalities in this area. And so let's move on and talk about what those causes, what those abnormalities are that can lead to compression. So a very common abnormality that can lead to compression or damage of these nerves and vessels is a cervical rib or fibrous band coming off the rib. Normally the first rib comes off of T1, but about 1% of the population actually has a cervical rib coming off of C7, as we can see in this x-ray here. Here the arrow is pointing out that cervical rib on this patient. And so while cervical ribs are usually asymptomatic, it can lead to thoracic outlet syndrome. Additionally, a pancreas tumor, which is a type of lung cancer that usually grows in the apex of the lung, can grow large enough to compress the structures in this area and lead to this syndrome. Because these neurovascular structures are also running so close to these neck muscles, if there's hypertrophy of those neck muscles, that can also compress these structures. Making up the scalene triangle, the middle and anterior scalene muscles can grow large enough to compress the vessels. Additionally, although it's cut in this image, the sternocleidomastoid can also grow large enough to compress these vessels, which is something we might see in baseball players or other athletes. And lastly, poor posture or excessive tissue from obesity can also compress these neurovascular structures. All right, let's move on and talk about presentation. What does it look like when we have a patient with thoracic outlet syndrome? As I mentioned before, there's really 3 different structures that can be compressed in thoracic outlet syndrome. Compression of the lower trunk will give us a neurogenic TOS. Compression of the subclavian arteries will give us an arterial TOS, and compression of the subclavian vein will give us a venous TOS. Keep in mind that a patient can have 1 or 2 or all 3 types of compression. So let's go over each so that you can tell what structure in your patient is most likely compressed based on the presentation. Let's start with compression of the nerves or neurogenic thoracic outlet syndrome. It's important to mention that this is by far the most common. 90 to 95% of cases are neurogenic. So we'll often see pain or weakness in the arm and hand, especially with gripping motion. As we mentioned, that median and ulnar nerve are going to be predominantly affected by the lower trunk injury, and all of the intrinsic muscles of the hand are innervated by either the median or ulnar nerve. The patient may also have a paresthesia, classically in the ulnar distribution, which may be down the medial side of the arm and hand. There will also be atrophy of the intrinsic hand muscles. So on a physical exam, you may see muscle wasting in the affected hand. And lastly, there may be a reduced sensation in the C8 and T1 dermatomes here on the medial side of the forearm and hand. Let's move on and talk about compression of the subclavian artery, giving us arterial thoracic outlet syndrome. Let's think about this before we talk about the signs and symptoms. So if there's compression of the subclavian artery, there's going to be reduced oxygenated blood flow to the muscles of the hand and arm. That reduced oxygenated blood is going to mean that we're going to have fatigue and pain and even paleness in the affected hand. And that pain is more likely to be noticed by a patient if they're using the arm, especially any kind of overhead activity that may be worsening the compression. The patient may report that it's more difficult to do something like doing their hair, tweezing their eyebrows, swinging on the monkey bars. Additionally, because the artery is being compressed up the arm, the downstream arteries of the arm are going to have reduced flow. This may present with a decreased pulse strength or blood pressure, which you may notice on a patient, or be uneven between the 2 sides of a patient. If a patient's arterial thoracic outlet syndrome is very severe, it may present with paresthesias and similar to critical limb ischemia, where there's shooting pain in the arm. And last on our list of presentation, we'll talk about compression of the subclavian vein. So if there's compression of that vein, then we're going to lose blood flow returning from the arm. This will cause the blood to pool in the veins, which may lead to edema, pain, and distension of those veins. Additionally, because there's stasis or reduced blood flow, that's going to increase our risk of a venous thrombosis. And lastly, let's talk about treatment and how we can diagnose thoracic outlet syndrome. When a patient's history is suggestive of thoracic outlet syndrome, imaging can help us determine what is being compressed, where is it being compressed, and what may be doing the compressing. An X-ray will be helpful in determining if a patient has a cervical rib contributing to the symptoms, and an MRI or CT may be helpful in considering other softer structures that may be contributing to compression. And so again, if we understand the underlying cause, treatment is about addressing that cause. If there is the cervical rib or fibrous band compressing the structures, surgery to remove that will be the primary objective. If hypertrophied neck muscles, poor posture, or obesity is the cause of our symptoms, then physical therapy and weight loss will be critical parts of treatment. Additionally, if pain is a part of the patient's symptoms, then NSAIDs may be administered as a form of pain relief, and if a venous thrombosis has formed, then thrombolytics, such as tenecteplase, may be administered to break that clot. Alright, let's do a recap and then a practice question together. Thoracic outlet syndrome is compression of the neurovascular structures that are running through the thoracic outlet, or commonly in the scalene triangle. It can include compression of the lower trunk, subclavian artery, or subclavian vein. The causes can be from an abnormal structure such as a cervical rib, fibrous band, or Pancoast tumor, or poor posture and tissue growth compressing the area. The presentation of TOS will depend on the structure involved, with neurogenic being the most common by far. This can present with pain or weakness on the affected side, especially with the gripping motion, paresthesias, atrophy of the intrinsic hand muscles leading to something called Gilyot-Sumner hand, and decreased sensation in the C8-T1 dermatomes. One of the things that lets us contrast clumsy palsy, which is an injury of the lower trunk, to thoracic outlet syndrome, which is compression of the lower trunk, is that clumsy palsy is usually considered more traumatic, with a more sudden onset, while thoracic outlet syndrome, because it's compression, has a more slow and insidious onset. And so patients are more likely to present with atrophy of the hand muscles as thoracic outlet syndrome, whereas patients with clumsy palsy are more likely to present with claw hand due to the sudden weakening of intrinsic muscles of the hand. Unlike clumsy palsy, thoracic outlet syndrome can also lead to compression of the subclavian artery or subclavian vein. And treatment for thoracic outlet syndrome will be about addressing the underlying cause, either physical therapy and weight loss or surgery, and preventing complications with NSAIDs or thrombolytics. A 52-year-old female presents to your clinic after noticing difficulty gripping her golf club in her left hand. In addition to the weakness, the patient reports a tingling, painful sensation going down the medial portion of her arm when she braids her hair. Vital signs are within normal limits, and on physical exam, you notice 2 out of 5 strength with finger adduction and abduction on the affected hand. An X-ray of the patient reveals an overdevelopment of the transverse process of the 7th cervical rib. In addition to the brachial plexus, what other vessels are most likely compressed in this patient? This patient presents with weakened intrinsic muscles of the hand, as seen with the decreased grip and finger abduction and adduction. In addition, there is a painful tingling down the ulnar distribution of the arm, and an X-ray describes a cervical rib. So in addition to the brachial plexus, we also suspect that subclavian arteries or veins are likely compressed in this patient. Alright guys, that's everything from me today. Thanks for watching, good luck studying, and I'll see you next time. Howdy everybody, welcome back to MSK. My name is Jonathan, and today we are going over another pathology of the brachial plexus, winged scapula. Let's get into it. Alright, as usual, we'll start with our brachial plexus diagram, but this time it's a little different because we can skip all the madness that happens here on the right side of our diagram, because winged scapula is about a lesion to the long thoracic nerve. This nerve is nice and easy to follow as it just has the roots C5, C6, and C7 directly contributing to the final nerve. As I just mentioned, the pathophysiology of winged scapula will be an injury to the long thoracic nerve, which typically has the nerve roots C5, C6, and C7. The long thoracic nerve is a pure motor nerve and will innervate the serratus anterior, which has the action of pulling the scapula anterolaterally and stabilizing the scapula to the ribs at rest. So if we look at this image down here, we can see the serratus anterior, and it's named because it's sort of shaped like a serrated knife with its pointy parts sticking out. The serratus anterior will originate here on the medial side of the scapula, and then those muscles will reach around and insert onto the 1st through 8th or 9th rib. At rest, the serratus anterior will be responsible for helping the scapula to maintain contact with the thoracic wall. And as it contracts, the serratus anterior will move the scapula anterolaterally, sometimes called protraction of the scapula. Additionally, you can see that the fibers here on the bottom are nice and long, and so as those contract all the way, the inferior angle of the scapula is going to move a little more than the top of the scapula, which will cause an upward rotation of the scapula. This is how the serratus anterior helps to contribute to abduction of the arm greater than 90 degrees. As the deltoid approaches full contraction, the serratus anterior will help rotate that scapula and contribute to abduction over 90 degrees along with the trapezius. Additionally, because the serratus anterior attaches to the ribs, it can be an accessory muscle for inspiration. A little mnemonic that some people use is C5, C6, C7, raise your arms to heaven. And that's to remember the nerve roots of the long thoracic nerve, and also that the long thoracic nerve innervates the serratus anterior, which helps abduction of the arms above 90 degrees, helping this little man here raise his arms to heaven. Alright, let's move on and talk about causes of winged scapula. Commonly in a question, it will be an axillary nerve surgery, specifically a lymph node dissection along with a mastectomy. So for a patient with breast cancer, the most common place for the cancer to first metastasize is the axillary lymph nodes. So when a patient undergoes a mastectomy to remove cancerous tissue, there will often be a biopsy of the axillary node, sometimes called a sentinel node biopsy. And if that lymph node is positive for cancer, it will also need to be removed, prompting an additional incision. And so if we look at the course of the long thoracic nerve, we can see that it runs through the axilla. And so an incision and dissection in that area presents a risk to nick or damage the nerve. Additionally, the nerve could be damaged by a stab wound. One way I learned about this is that when someone is being attacked, they will instinctively raise their hands to protect their face. When the arms are raised, that can leave this area to be injured. But remember, the long thoracic nerve comes from cervical nerve roots, so the injury doesn't have to be in the axilla or down here at the level of the serratus anterior. It could be higher up, which may be the case in a stab wound, or more commonly seen in children, use of an excessively heavy backpack, especially if they just wear one side of the backpack. Children are weak and frail, and if you send them to school with a backpack that's way too heavy, and they wear that backpack on one side, that can cause compression of the nerve, which can then injure the long thoracic nerve and lead to winged scapula. So let's move on and talk about presentation. The classic presentation will be the medial protrusion of the scapula on the affected side, which we can see in this patient here. We can see that the medial side of the scapula is sticking out and is much more noticeable than on the healthy, unaffected side of this patient. Something that will emphasize this presentation is if the patient presses against a wall. When a patient pushes against a wall, as this patient is doing here, that force from the wall is going to want to push that shoulder and scapula medially. If the serratus anterior is healthy and intact, it will resist that motion. But in this patient, because it is not, the scapula will protrude medially. Additionally, the actions of the serratus anterior will obviously be impaired. So we will have reduced protraction of the scapula, which is the action of moving that scapula anterolaterally along the thoracic wall, and impaired abduction of the shoulder above 90 degrees, because the serratus anterior is going to be one of the muscles that helps us abduct that arm above 90 degrees. Note that it is still possible for a patient with a long thoracic nerve injury to abduct their arms to 180 degrees if the trapezius muscle, which runs along here, would adequately compensate for the lack of serratus anterior. And lastly, in addition to muscular weakness, the patient may present with pain in the affected shoulder and arm. And remember, the long thoracic nerve is a pure motor nerve, so we don't see the sensory deficits that we necessarily see with many of the other brachial plexus lesions. Alright, let's move on and go over treatment. Like many other lesions that lead to motor deficits, physical therapy to strengthen those weakened muscles will be an important part of treatment. In this case, a patient will undergo scapular stabilization rehabilitation, in which the muscles that stabilize and act on the scapula will need to be strengthened. And additionally, in very severe cases, surgery may be necessary to repair the nerve. Alright, let's do a quick recap and then we'll do a practice question together. Winged scapula will be an injury to the long thoracic nerve, which comes off of the nerve roots C5, C6, and C7. This will affect our serratus anterior, which is responsible for anterolateral protraction of the scapula, stabilization to the ribs, and that upward rotation important for shoulder abduction above 90 degrees. Common causes would be an axillary node surgery, a stab wound, or a very heavy backpack that compresses the nerve. Patients will present with a medial protrusion of the scapula that is worsened by pressing on a wall, and weakness and pain of the shoulder and arm. And treatment will involve physical therapy to strengthen muscles and surgery if very severe. A practice question might sound something like this. A 59-year-old female presents to your clinic with shoulder weakness 5 weeks after her mastectomy and axillary node dissection. The patient reports that she has been unable to reach any of the high shelves in her home. On physical exam, the patient has intact sensation on the arm and shoulder, but cannot raise her arm above the level of her shoulder. Additionally, there's a medial protrusion of the scapula on the left side that is worsened when the patient presses on the wall. What are the nerve roots of the most likely affected nerve? So as you were probably able to deduce, this patient has a long thoracic nerve injury, likely from her lymph node dissection. We see a medial protrusion of the scapula in addition to impaired abduction and pain in the affected arm. And if you remembered our mnemonic from earlier, C5, C6, C7, raise your arms to heaven. So those will be our affected nerve roots. Alright, that's everything from me. Thanks for watching. Good luck studying, and I'll see you next time.